My name's Jenny Stevens, and I'm one of the clinicians from St Vincent's Hospital in Sydney who helped to develop this website. I'm so grateful to Andrew for sharing his family story. You might think that the prescribing he talked about is so far from your routine prescribing that it doesn't have any relevance to you. But I think it goes to the heart of what for me are the two most important points on the Rosie website. We recognise that people feel overwhelmed when it comes to opioid stewardship and don't know where to start, so I just want to go through two basic points. The first point for me is that we should have simple, age-adjusted prescribing guides widely available to prescribers, to nurse educators and to pharmacists within a hospital to reduce the kind of outlier prescribing that you've just heard about. The lanyard that we've developed is on this website if you want to adapt it for your own hospital. I think the lanyard is especially important for junior staff so that they feel more confident and don't just use underdosing as a way to feel safe in their prescribing. If you're in a small or a regional hospital where you might not have a pain specialist to devise your own guide or lanyard, then by adopting those from other hospitals or the one on this website, you can spread up-to-date information easily and ensure that your postcode is not the determinant of the analgesia you prescribe. By including nurse educators and pharmacists in the distribution of these guides and lanyards, you get another layer of safety. Everyone should be able to recognise what is outside the box and question a prescription. So, firstly, make a guide or lanyard and distribute it widely. The second point is that for opioid-naive patients with acute pain, these guides or lanyards should not include modified release opioids. They don't improve analgesia, and there's very good evidence for increased morbidity. It's really interesting that the Wollongong experience showed that in their in-hospital respiratory depression rates stayed well above the New South Wales health averages, despite extensive use of atypical opioids, but dropped rapidly with the introduction of prescribing guides that didn't include modified release opioids for acute pain in opioid-naive patients. So I think those are the two most important steps you can take. The most common question I get asked is, well, what's wrong with a couple of days of slow-release tapentadol? And I agree, it doesn't carry the same immediate risk as the prescribing in Andrew's story. But for me, it raises a couple of points. What's happening with your immediate release prescribing? Are you thinking that actually your immediate release prescribing is not enough without the MR because your immediate release prescribing is not ideal? Immediate release dosing needs to be age-based to make allowance for the much higher opioid doses generally required in the younger patient. Also, is there a dosing interval that's short enough? If you're prescribing 6th or even 4th hourly dosing for severe pain in the absence of impaired metabolism, it's probably not going to be enough, especially for younger people. I sometimes see a second oral opioid charted for if the first type doesn't work. If the problem is initial poor absorption after an operation, then a switch to frequently available PRN subcutaneous morphine, for example, can be a really good first step. It may be a better option in that first 24 hours, for example, than enabling more risky dose stacking with multiple oral opioids. We know that if you prescribe a modified release opioid at the point of discharge, then the chance of that patient still being on those opioids 3 months later is 5-fold without any improvement in their pain relief. When you prescribe the 2 days of modified release opioid, your intention is that it will cease, but it's precisely the patients at increased risk of unintended persistent opioid use who may have more pain in hospital and so have the modified release extended with or without the knowledge of you, the original prescriber. The level of evidence within acute pain is increasing. We've also got some good Australian evidence now. I think this allows us to move from the every prescriber for themselves days to something more like antibiotic prescribing with high-level documents like the Clinical Care Standards and the FPN position statement on acute pain management, supported by local resources adapted for local conditions that can be easily updated and shared widely. So while I love a good audit, and the respiratory depression one is very easy because the hospitals collect it for you, I would say that if you want to do only one thing to improve prescribing in your hospital, start with a simple acute pain prescribing guide or lanyard that doesn't include MR opioids for the opioid naive.